Presentation from Chris Viel with regards to the Conference Board of Canada funding report. Before I introduce him, I just want to give you a little bit of history. This is the second time that CAPA has contracted the Conference Board of Canada to create such a report. The first one was produced in 2016 and was an invaluable resource as we negotiated with potential employers and government agencies about how PA should be funded and compensated. And it was such a great tool for us that we decided we would contract them again to have a look at updating it as things have changed. So I really look forward to this updated report, and I'm certain it was going to provide us a lot of helpful information and statistical analysis that we can use when communicating how PA should be funded and compensated. So I'd like to introduce Chris Viel. Chris comes from an interdisciplinary background in both core and social sciences, holding undergraduate degrees in both biology and gerontology. Following this, he completed his master's in health science and epidemiology at Lakehead University, where he received the Frederick Banting and Charles Best Canadian Graduate Scholarship for his multi-province work, examining the impact of supervisor workplace mental health training. In February 2023, Chris joined the Conference Board of Canada as a research associate with their health knowledge area. He has a diverse resume in both clinical and applied research, with experience in the fields of mental health, workplace, workforce injury and disability, seniors healthcare, and Indigenous health. In addition to these experiences, Chris has a keen interest in health policy, economics, and outcomes research, which have been the focus of his mentorships and professional development over the last 3 years. So Chris, thank you very much. Look forward to hearing about this.
Amazing, and welcome everyone. It's such an honor and a pleasure to be opening this conference. We've been working so hard at this for the last, I guess it's been close to 8 months now, and it's amazing to kind of see our work come to fruition, and we've got some exciting announcements towards the end of this presentation. Awesome. So there's a few familiar faces in the room today. That's obviously been through the progress of this project, but I thought I'd do a quick introduction to myself. So my name is Chris Viel. I'm an epidemiologist by background, and I'm a research associate with the Conference Board of Canada in their health knowledge area. As Bill already mentioned, I have a kind of diverse clinical and applied research background. I had the very unique privilege to look at a multi-provincial study between Manitoba and Northern Ontario, specifically looking at the forefront of the mental health crisis that a lot of organizations were facing. Uniquely enough, one of the main reasons I was able to get my scholarship was because the Conference Board of Canada was actually releasing a report, and they were one of the first people to actually look into workplace mental health. So it's a weird that we've come kind of full circle and I ended up as an employee there. And like Bill said, I really have a keen interest in health policy, health economics, and outcome research. I have a number of mentors in the field through industry and academics. And this is really kind of driven to where I am today, and really kind of lined up well with my position at the conference board. Before we get started, there's a number of acknowledgements we have to make. This was a gigantic project. There was so many people involved in it, and I really wanted to mention all of them and give thanks. First and foremost to CAPA. So CAPA is the funder for this project. Both Christy and Patrick, I can't thank you guys enough. I know many reviews and iterations of this report. We can't thank you enough for your support. Yeah, it means so much to us, and especially to be here today to show you guys the accomplishments that we've all achieved. CAPA would also like to acknowledge a funding contributor for this project, which is the Alberta Medical Association, and I can't go without acknowledging both of my colleagues who assisted with this report, another research associate, Micah DeVries, in the Health Division, as well as the Director of Health, Chad Lever, who's been my mentor through this entire project. I just wanted to mention at this point, I have no conflicts of interest to disclose, but I do have one more massive thank you, okay? If you guys are involved in any sort of research at all, you guys know the value of a research advisory board. I've had the absolute unique pleasure of every advisory board I've been a part of has been such a fantastic opportunity. I think that, you know, as researchers, we can only take things so far, and really to ask those tough questions and actually get information from people with feet on the ground, I think is the most important, and that was exactly the case for this project. I think everyone from Owen Adams to Kristen Burrows, Dr. Jim Wright, Dr. Neil Gibson, David Coons, Dr. Tommy Gershman, and Sahan and Safi, All of these individuals play a very unique role. Many of them are here today. And you'll see a little bit later on, these people played an absolute pivotal point in many of our data points that we had to do for accomplishing our model. So, some of you might not be familiar with the Conference Board of Canada. So it's Canada's foremost independent research organization. Really, our focus is on facing Canada's toughest problems. So not surprisingly, a number of our knowledge areas line up with kind of the policy issues that are going on within Canada. So we have areas in healthcare, we have areas in inclusion, Indigenous and Northern communities, economics, education, skill development, and that's just to name a few. So this is where the report is going to be published, so I encourage all of you guys to take a look. You can look at the previous 2016 to 2017 research series as well, but it's an awesome opportunity to check out some information, and we try to keep it as updated as possible on the biggest issues facing Canadian healthcare systems. And that brings us to the project. All right, so give you a very brief outline of what we're looking to do today and looking to accomplish. We're looking to really set a foundation overall, give you a little bit of a project rationale, what has brought us here today, and then we're going to really go over the physician assistant's position within Canada and update those figures from 2016, 2017. From then, we're going to start talking about physician assistant impact potential in Canada's healthcare system. Then we're going to really dive into the model. So for those of you, we're going to have a little bit of density to some of this project and some of this presentation. So bear with me for some of it. I've tried to make it as user-friendly as possible. But basically, we explain the model characteristics, and then we really talk about the implementation across practice settings. So we were really interested in areas that where PAs were already established. So we're looking at primary care, emergency medicine, and orthopedic surgery. After that, we'll talk about model impact, and last but not least, we'll have a quick discussion on future direction. So as Bill mentioned earlier, the Conference Board of Canada had performed a research series on physician assistants starting back in 2016, where we looked at understanding the role of physician assistants within health systems. We then published the increasing use of physician assistants within Canada, so we looked at more of that Canadian context, and then we published really an update on Canadian international funding models for physician assistants, followed by recommendations for actions. And that brings us to today. So one of the things we really noticed was there weren't a lot of changes since these 2017 reports. Obviously, there has been progress in the profession across Canada, but many of the barriers still facing PAs of further integration into the provinces, as well as the conversation about the standardized funding model or standardized funding model across Canada, are still in question, okay? So this really led us to our objective to provide insight into the optimal utilization of physician assistants to enhance their presence across Canada's healthcare systems, while also keeping a keen eye on optimizing system costs. So I'm gonna just drop this right here, okay? It was mentioned in the earlier conversation from the Canadian Medical Association. I think there's no way from hiding from this, okay? If you've turned on the TV, if you've looked at Google News, opened a newspaper in the last 3 years, I think we can all agree and seen that healthcare in Canada is currently in a crisis, okay? And that is one thing that I think that we can't avoid. Not to be a Debbie Downer 9 minutes into the presentation of this conference, but I think really where we wanted to start this presentation was kind of establish this and really acknowledge that actually there is light at the end of the tunnel. And physician assistants really offer an opportunity and a very unique role to actually address many of the challenges facing our healthcare system currently. All right, so we're gonna dive into a little bit of a pulse check. So these are gonna be updated figures from our 2017 reports. Currently, there's about 902 physician assistants across Canada. Currently, civilian PAs are working in Manitoba, New Brunswick, Nova Scotia, Alberta, Ontario, and Saskatchewan. Now, one unique, since we've been doing this the last 8 months, there's been a ton of progress in this profession, okay? I know Patrick and I have been going back and forth on adding additional content, and we kind of hit a peak within the last month when BC added this piece to their legislation as well. So unfortunately, we weren't able to add that piece to it. But it's amazing to see the progress that this profession has made in the last 8 months. The next thing I really wanted to note, we don't go into the specific funding models for these provinces in this presentation. If you guys want to take a look at the report, they've got all funding model updates in that report. It goes into a lot of detail. For the length of time I had today, it was going to take a little bit too much time, but if you guys are interested, it is contained into the report. So after diving into this, we would look to really, like I said, get a bit of an updated pulse check on where things are today. And what we found is there's a lot of the still same problems facing from 2017, okay? We have a lack of role integration across the country. We have a lack of standard funding opportunities. And then the provinces that are integrating PAs, we still have provincial funding opportunities that are variable and limited, okay? Not to say that all provincial funding opportunities are limited and variable, but for the most cases, this is what the literature would support. In addition to this, we have a lack of accommodation as part of the provincial colleges of physicians and surgeons, as well as a lack of accommodation as a regulated healthcare profession. So what does this mean for PAs? This ends up in resulting in short-term contracts, lack of job security, and reduced opportunity for integrated practice and presence. So it really reduces the sustainability of this profession and further integration across the country. Next step of this project was to really establish some things. So we wanted to look, how can we enhance medical practice? How can we really make an impact on our Canadian medical system? And so our first thing we really wanted to do was answer that question. How do you enhance practice? Well, you need markers of measurement for that, okay? And after we dove into the literature, we found these 5 markers came up time and time again. So we want to look at increased practice efficiency, we want to look at increased patient care capacity, increased job satisfaction, decreased physician burnout, as well as increased patient satisfaction. These are all markers of enhanced medical practice. But how do you achieve this, okay? And the thing, basically, we found unanimously across all the data, the arrows pointed towards team-based care. Now, it's a very broad term, right? And it means something different depending which practice setting you're in. Primary care versus emergency medicine, those teams look very different, so your team dynamic looks very different at the same time. So we really wanted to kind of look into this a little bit further into the literature and really see how we can approach this team-based model of care. First and foremost, people need to be on the same team, okay? The setting needs to have promotion and expansion of team-based models of care, and we need to understand that this model of care reassigns tasks to designated health professionals within a team, whether that be a physician assistant, whether that be a nurse practitioner, whether that be a medical assistant. It's not limited to these roles, these are just a few examples. But what this does is it understands that people have a scope of practice. It understands that people have expertise in various fields, and we're able to lean on each other to more efficiently create this well-oiled machine, okay? As a result of this, what we find is that we have enhanced team collaboration to prioritize workflow, we have improved access to care and services, and we have the potential to increase the number of patients seen in these practice settings. How does a PA fit into this more specifically? Well, we found that the literature produced that for newly graduated PAs, they noted that PAs can increase the scope of generalist services provided. Now, that being said, it's not always the case, okay? If we look at our next point here, we point out increased PA experience, okay? As physician assistants increase experience and that dynamic between the supervising physician and the PA increases, there's the exact opposite. A lot of the times, and we found this in a lot of our key interviews for this project, the physician assistant, an example for primary care, was actually seeing half the amount of patients as the physician because the appointments were twice the length, okay? So that complexity of patient care actually went more to the autonomous, went more onto the PA, and actually the physician was seeing some of the more general services provided. So it's interesting, it goes back and forth, and it proves that this is the whole value of these expert reviews and these RAB conversations, is because the literature might say one thing, but there actually might be opportunity to kind of redirect and kind of reframe things moving forward. Now to talk about the elephant in the room. It's my favorite slide. It's mentioned in the report, so I think it's worth mentioning here. Okay, amongst the literature, there is, and I don't think this is going to be a surprise to anyone, there is note to enhance medical practice, especially noted by many physicians, to delegate a lot of the administratives and medical scribe tasks to PAs, okay? In all honesty, our vision for PAs is much greater than that, okay? Your training and expertise should be patient-facing, okay? So if we're going to address this twofold, we're going to address the medical scribe piece first, okay? There is trained medical scribes whose job that this should be. Okay, and not only that, and this is again something we've learned in our expert reviews, a lot of the physicians did enforce that AI technology has been kind of pushing towards the medical scribe role, and that's something we need to consider moving forward. So again, this pushes that responsibility off the PA, and again, we see more PAs in the more patient-facing roles. Now with regard to administrative tasks, as a healthcare professional, that's unavoidable, okay? But I think really what we're chatting about here is that the physician's not putting the administrative tasks on the PA. I think what we're more going to be experiencing moving forward is task sharing, okay? If somebody has a more busy day than the other, then we can balance these tasks to create a much more well-oiled machine, and we're not just kind of dumping everything off on the PA, all right? So this is noted in here. We just kind of wanted to address that right off the bat. So in summary of our kind of background research on this, really, we know that PAs have tremendous amount to offer to Canadian medical practice. We all know that already. But the biggest thing here is that we know that patients are at the forefront of potential impact through both direct and indirect, both indirect benefits. All right? Not only that, in a service industry or in the healthcare industry where we hear so often that funding is at the, I've kind of drifted over, where funding is at the forefront of many of the issues facing the healthcare system today, what we can find is that PA integration can really add a lot of value-based transformation to our healthcare system. And how do we do that? We can look through a couple avenues. Number one, we can have a reduction in wait times with the potential to improve management and continuity of patient care. We have the opportunity to improve physicians' quality of life. That one might be contentious. We're going to talk about that a little bit later. And last but not least, there's a lot of positive contributions to productivity. A good example of this is just simple by increasing the number of services provided. All right, let's get into the model. All right, this is this next portion, like I said, it gets a little dense. I've tried my very best to simplify things, but stay with me a little bit here. So first and foremost, we needed to create a conceptual model. So we needed to figure out some way to measure this efficiency and figure out how physician assistants can impact patient or healthcare practice. All right. First and foremost, we needed to pick funding streams. Okay. We're going to be looking at public funding model, and we're going to be looking at employer remunerated funding model. For the public model, all of these funds come from public dollars or government spending. Okay. So a good example of this is going to be the government paying directly for a fee-for-service from a physician assistant. On the other hand, we have employer remunerated funding model. You guys are going to see at some instances, we've tried to be very careful in our word selection for this, but you're going to see in some of the instances, especially in the tables, we refer to it as a private funding model. All we mean by this private funding model is that it's employer remunerated, whether that be through a physician group, a practice setting, or some sort of grant or something like this. Yep. Yeah. Oh, no, now it doesn't. It was. Yep. Awesome. So now that we've picked our funding streams, we need to really figure out our intervention and our control strategy, okay? Basically, what you're going to see is we're going to have a reference model, which is the status quo. So it's going to be the current number of services provided in our current healthcare system by a physician-only practice setting, okay? So basically, all that is the exact data that we pulled for this project, current statistics for the data year that we're looking at, that's the one, okay? Physician-only model. And then we have our intervention models. This is where we incorporate the PA and assume the PA physician role in this scenario, okay? Now, I want to make a couple other notes quickly. What you're going to be noticing moving forward, since we have two reference models, they're identical, okay? So when we do represent this moving forward, especially when we start breaking down the model and looking at the model comparison, you're only going to see one reference model. We don't need to include two. They're exactly the same. So what do we do with this? What data do we need to include to actually be able to answer the questions we're after today? So first and foremost, we need to know the number of services provided. We used CHI data for this for the fiscal year 2020 and 2021. We'll go into detail a little bit later on and why we picked that year. Next, what we were looking at was to actually get the mean physician cost per service. This is quite easy. CHI did this for us. It's a pan-Canadian data set. It's got the average cost per service incorporating all of the provinces and territories. After that, we're actually looking at the PA cost per service. So we calculated this as a discounted physician cost per service. All right, we look at this a little bit later. We're closely mirroring the US system of that reduced fee for service. After that, we have two variables that we used expert review to figure out. First and foremost is the mean duration per service. So how much time were physician assistants actually participating in these service on average? Next, we looked at the mean proportion of PA involvement in the service. So how often are PAs performing this service versus the physician in their practice setting? Now we get to a couple model assumptions before we actually look at the calculations themselves. So as I noted before, we are using a fee-for-service model, all right? We wanted to parallel the successful discounted fee-for-service that's currently used in the United States. An example of this is the 85% of physician fee-for-service and for Medicare reimbursement, all right? One important note to that, and what we did not replicate from the US system, is that we did not incorporate incident to billing. So whereas the physician would be able to bill for the remaining portion of that service, effectively there'd be no savings to healthcare system, therefore we did not include it, okay? Last but not least, we did note that discounted fee for service were reflective of current average PA salaries. That was really important to us, and actually what we actually saw was an actual increase in salaries for PAs, which I'm sure you'll be all happy about for this model. But that is something important to note, that we did try to make some sort of replication, some sort of parallel with current salaries, as well as trying to reach a status quo of, we'll go into that a little bit later when I have it on the screen. Last but not least, we'll talk about PA regulation structure. So all models are going to assume supervision from the attending physician as per Canadian legislation. But the level of physician supervision varies by practice setting, PA experience, and physician or PA professional relationship. What we really want to note here is this is going to vary. It's going to vary by PA experience, all of the variables that we've just included here, okay? So we've tried to use, to our knowledge, and gather as much information as possible to make informed decisions about these data points. But what this means is that these things can change, all right? These are variables that obviously it's going to be an assumption for this project, but we can actually plug different calculations into this model and come up with a little bit different results, but that should be noted right off the bat. Last but not least, we have not included any non-covered elective surgeries. So since PAs are able to participate in non-covered elective services, this would obviously add to their earning potential. We have not included that for any of these models. And now the fun stuff. All right, so this is really where the rubber meets the road. This is where we actually started incorporating healthcare data and really applying it to see what impact physician assistants could have. So first and foremost, we needed a total number of cost of primary care services for our data set here. And it's about $6.71 billion per year, all right? The next thing we wanted to know, how often are physicians participating in services within a PA's scope of practice? So where can we really insert the PA there to make the most impact? And what we found was that physicians in primary care were spending about 28 million hours per year across Canada on services within a PA scope of practice. Next, we looked at average PA working hours for primary care. I understand this might not be universal across the board. Again, we tried to use best informed information for this, for these data points. We understand that this might change amongst individual and practice setting, but this is what we use for this current model, okay? And what we assume for this is that it's approximately 37.5 hours per week for these physicians, and that equals a total time savings or a total, integration of PA of about 2.1 million hours. What that means is that the PA could effectively be incorporated into primary care and save primary care physicians about 2.1 million hours per year, which is 7.3% of that total 28 million hours, okay? That's another important key I just wanted to note today. When we talk about that 28 million hours, you're gonna note that it's within services that are within a scope of a PA's scope of practice. And that's the percentage moving forward. It's not the total percentage, okay? We don't know how much time physicians are spending on other services provided, so we left those out. Obviously, they're incorporated in the billing and everything like that. But if we're actually gonna try to assume time savings, those are left out, all right? Now the fun stuff, all right? If we were looking to save those over 2 million hours per year, effectively it would take about 1,145 PAs injected into the system to have this time savings, and at a 75% remuneration of physician fee codes, we'd be looking at a cost savings of almost $44 million per year. We understand that that's not gonna happen tomorrow, okay? For the purposes of our model, we are including the 100% injection into the system. However, I'll explain a little bit more clearly why we've chosen to do that, okay? I have included a little bit below, we have 50%, 25%, 10, 5, 2, and 1% of that total 100%. And I think that's gonna give you some idea of what that time and cost savings would look like, and that's gonna be on a short-term basis. If we look at a long-term basis, there's about 48,000 primary care physicians across Canada, and so it wouldn't surprise me that in the next 10 years or so, that these numbers would be feasible, okay? So I think what we're looking at is really the total and potential impact for PAs in this practice setting and across the other practice settings we're looking at. Therefore, that's what we choose to work off of. If we ever wanted to, again, we could model these at a lower percentage again. Now it's time for the analysis and model comparison. So for our purposes today, you're going to be seeing two scenarios, okay? As we all saw on the previous side, we had a 7.3% increase in time that the PA was going to be saving this physician, okay? We're going to look at two scenarios. First scenario is that that physician is going to put that 7.3% completely back into practice. So bump up service provision, but bump up billings as well, okay? The next scenario we're looking at is a split, and this is likely more realistic, but a little bit more of a hybridized model. The first is we're going to look at a percentage of time that the physician is going to put back into practice, and the other one is going to be a physician is going to have time for non-patient care activities. And we're going to go into a little bit more detail why that might be advantageous. Now, for all you lovers of quantitative data, I can assure you this is not how the rest of the presentation is going to go. What we wanted to do is really give you a representation and walk you through an understanding of how we arrived at our conclusions, okay? We're just going to be looking at this table. This is going to be the table that's represented in the report, okay? We're going to walk you through it, but for the rest of, emergency medicine and for orthopedic surgery, it's going to be a little bit more simple, all right? So first things first, you're going to notice under public funding model, we've got an A, which is the control, we've got a B, which is the experimental, and we've got model D, which is the experimental for the employer remunerated. We've taken out table C, which is that other status quo or control model, okay? First things first, we're going to look at the cost to the public payer. So this is the total fee for service billing, okay? You're going to see two physician categories. The first physician category is basically the status quo, the number of services provided baseline. All right, so if you see the status quo, we've got $6.7 million charged because of physician fee for services. All right, we'll poke over to experimental model B. Okay, so we have that. We basically have $6.5 billion in service provision. That's reduced because now we've injected the PAs into this model. Okay, however, we see an increase in service provision from the physician, so we have an additional fee on top of that. Sense? And then we also have the public payer assuming or absorbing the salary of the PA. If we look at the experimental, it's almost identical. The only difference is the private or the public payer is not absorbing that the salary of the PA. The next line we want to focus on is cost of private payer. So this is the independent employer, okay, like we talked about. And basically, we're just looking at physician assistant service provision, the fee for service. Now we've shifted from that public salary remuneration to the employer remuneration. Last but not least, we want to talk about practice efficiency. Okay, effectively in the status quo model, there's no increase in practice efficiency because we haven't incorporated PAs. If we look at both experimental models, we have that 7.3% increase in service. And what that effectively means is that we're actually increasing the number of services provided in primary care across Canada by over 4 million services, which is quite substantial. Last but not least, we need to look at the overall cost to the public payer, okay? If we go across the board, we have the status quo of $6.7 billion. If we look at the public payer absorbing the cost of the physician assistant, in addition to the increased costs and services for physicians, we're looking at actual net loss to the public, or net cost to the public payer of about $131 million, okay? We still get that increase in service provision, but we're getting that increased cost to the healthcare system, which policymakers don't like to see often, all right? If we go to the next tab there, we have that total cost to the public payer, about $6.7 billion again, effectively at a cost neutral or exactly the cost savings as we are, or effectively at the exact same expenses that we are right now. However, we see that the physicians actually have an increased earning potential of about $43 million even after they've paid for the PA salary. Now, this is the scenario analysis one, like I said, where we're just incorporating that full 7.3% back into physician practice. And here is really where things get a little bit more fun, all right? So now is where we actually get to play with that percentage of time a little bit, okay? So we would effectively say the physicians are going to put 5.5% of that time back into practice, but we're getting that 1.8% of time for non-work related activities. It might be small, but it might mean the difference between getting out on time and staying an extra 2 hours at the end of each day, all right? If we look at the actual figures after this, okay, first and foremost, for the public payer system, we still see that cost of an extra $88 million per year to the healthcare system. Again, not fantastic. But if we switch over to the employer remunerated model, we essentially see an actual cost savings of about $43 million to the healthcare system and about a cost neutral approach for the physician. So now we're getting an increase in services, we're getting cost savings to the healthcare system, and we are essentially getting, basically the physicians are getting an extra time to do what they please, okay? And like I said, we're gonna go into that a little bit more in detail later. If we look at the model parameters, so finishing up with primary care, it basically worked out to be a discounted fee for service between 75 and 80%. For this model, we use the discounted fee for service of about 75% of the physician's fee schedule. That would basically, which would effectively represent the salary of a newly graduated PA. Salary range for that was in between $114,000 and $122,000, okay? This can obviously change. This can obviously be worked with. This is basically worked on current average salary ranges and roughly trying to stick around that for now. Like I said, we can still play with the model. Let's go to emergency medicine. This is where we start seeing a little bit more impact. So emergency medicine, the total cost in 2021 was $5.67 billion. There's about 4 million hours that physicians were spending amongst services that PAs could provide. And for the average working hours, we looked across the board, we did expert interviews and saw what data was available. We saw about 9.2 hours per shift and about approximately 16 shifts per month. And this gave us a total time savings of about 3.2 million hours, or 80.1% of that time that the physician is spending on services within PA scope of practice. If we were looking to really make those changes, we'd be looking to inject about 1,800 PAs into emergency medicine for that time savings and the cost savings a year of almost $431 million. Okay, so crazy. So if we look a little bit more there, we can actually look at likely more, I guess, short-term trajectories. We can look at the 50%, we can look at the 25%. But like I said, we're going to be including that 100% injection for our model. Now in a much more simpler version of what we were just looking at. So if we look at scenario analysis 1, that'd be where the physicians are injecting that 80.1% time savings back into the healthcare system. What we're going to see first and foremost is a massive increase in service provision of almost 10 million services, okay? But that comes at a substantial cost to the healthcare system of almost $200 million. If we look at our experimental model with our employer remunerated funding, we still get that 10 million increase in over 10 million services provided. We effectively get a cost savings of about $18 million to the healthcare system, and we have an increased earning potential for physicians of about $413 million. Now let's go to the next scenario. So this is really the interesting part. So now we've taken effectively 52% of that time savings put into non-work related activities. And this is where we see the big impact, okay? If we're looking at our experimental model from the public payer perspective, we've got about 4 million additional services that we can provide with this model at a cost of about $211 million, or actually at a savings of about $211 million per year. If we look at our employer remunerated model on the right there, we still get that 4 million increased service provision at a huge cost savings of $426 million to the healthcare system. It's massive, as well as basically a status quo increased earning potential for all emergency physicians across Canada of nearly $5 million. For emergency medicine, we used a discount fee for service of 30 to 45%. Might seem low to a lot of people, but this is what it effectively worked out to be, okay? That 30% was again likely to mirror the salary of a newly graduated PA with a salary range between $102,000 and $155,000 a year. And our last one, bear with me guys, this is the last one we're gonna be looking at, all right? Orthopedic surgery, okay? So total cost of orthopedic surgery, I have a typo there, I apologize, is about $600 million per year. The amount of time physicians are spending on services within PA scope of practice, 1.7 million hours. And we're looking at about 7.92 hours per shift, about 4.12 days per week, all right? What this amounted to is about a 40.8% increase in time that the physicians were able to apply to other activities. If we're looking to make that injection right away at 100%, we'd be looking to interject about 423 orthopedic surgery PAs into the system at a cost savings of about $115 million per year. First scenario analysis we see here. First and foremost, we're looking at that 40.8% full 100% injection of time back into services by the physician. What we see is over 1 million additional services provided at a small savings to the healthcare system of about $1.5 million. When we look at our experimental model, we're looking at the exact same amount of increase in service provision, however, at a savings of almost $60 million to the public healthcare system and an additional earning potential of $56 million for our orthopedic surgeons. If we look at the other, if we look kind of switch into the scenario 2 analysis and apply a percentage of that time towards non-work related activities, we're still looking at an increase in service capacity of about 700,000 with an increased savings of about $57 million for our public healthcare system. Our preferred model would be the employer remunerated model, where we're still getting that service provision. We're getting a much higher increase in that public healthcare savings, as well as essentially a status quo or effectively zero or no increase to the earning potential of the physician. However, they are getting the increased time. Orthopedic surgery, very similar to emergency medicine. We were looking at about a 30 to 45 discounted fee for service, which effectively gave us a salary of about $117,000 to $156,000 per year. Now we can take a big sigh of relief. All right, the done stuff is done. All right, so now we get to put this is where the rubber's gonna meet the road on impact. All right, we're gonna review all of these models. We compared all these models. And really, our big question here is, where can we make the impact? Where can PA integration impact the Canadian healthcare system? First and foremost, we can have a decreased cost to the public healthcare system. Okay. Number 2, we could have the potential for decreased wait time. Number 3, we have the potential for increased number of service. We have an increased physician time. Again, we'll talk about that a little bit later. And last but not least, we have the potential for increased access to primary care. All of these things are major issues that are facing the Canadian healthcare system today, and these are something that PA integration can address. Let's talk about them one by one. First and foremost, we have the decreased cost to the public healthcare system. All right, we saw this in almost all of the models that we looked to calculate. But in some instances, we saw almost a $426 million savings by injecting PAs into this system. Not only this, we have obviously the direct benefits are there. We saw an increased cost savings across the board. However, we have indirect cost savings, which are really important to address here, okay? With that increased service provision, with that increased access to primary care, what we could really see is, number one, we could see a greater continuity in access to care, which, coming from an epidemiologist, really hyped up about that upstream approach. We could really address that disease prevention option as well, okay? We could really look at people getting better access to primary care, really increasing their health overall and their interactions with the healthcare system. Next, we talk about decreased wait times. So, emergency medicine and orthopedic surgery really were our big markers that we really wanted to chat about here, okay? It's been no surprise that since 2021, wait times in emergency medicine have been steadily going up, okay? If we can address that, that's a massive win for both the healthcare system and the patient population. In some instances, across a 6-month course in the last couple of years, we've seen some emergency rooms, especially in rural and remote communities, closed for over 530 hours. So if we can address these issues, massive impact. Next, we want to talk about orthopedic surgery. A recent study, I believe it was from 2022, saw that about 62% of patients received their joint replacement within the 182-day time frame. Okay, that's leaving our 38% past this threshold. So if we can really address this backlog, especially since the recent pandemic, it's going to have big potential. Next, we want to talk about increased number of services. I think these numbers speak for themselves, but if we're looking to increase services by over 7.6 million services across these practice areas, what's the potential if we were to look to expand this to other practice areas? So I think that, again, I think it speaks for itself and the potential it has. Next, we can have a decreased backlog for appointments and procedures, very similar to what we just talked about before. And last but not least, we have the potential to decrease that burnout of healthcare professionals across the board. This is the part I know we've chatted about, it's been mentioned, but the fact of increased physician time and what that really means, okay? So first and foremost, PAs are at a very unique position to actually influence this statistic, okay? If you do any reading or any literature search on how to reduce physician burnout, honestly, the solutions that have been come up with in the last little while are quite atrocious, okay? I know I was reading one report that said, in order to reduce physician burnout, they should be given more time during the day for, activities where they can, take a breather during the day. Nobody wants to extend their day more, okay? So really, where we need to, we're trying to get home at the end of the night, right? We need time for professional development. And if we're looking at the statistics right now, we're looking at about 1 in 2, this is from the Canadian Medical Association, we're looking at about 1 in 2 physicians and residents reported high levels of burnout, especially since the pandemic, okay? PAs are in a very unique opportunity to work as a team with the supervising physician and reduce this burnout. So I think that this has huge implication for both patient-facing and non-patient-facing time, okay? We didn't speculate, we didn't hypothesize on what these physicians would be doing in their non-patient related time, but that's up to them. It's likely, in some specialty areas, the physicians are gonna put that 100% time back into practice, okay? So again, increasing more service provision, but some physicians are gonna take advantage of that and actually be able to get out on time. Last but not least, we want to address the primary care issue, okay? As mentioned before from the Canadian Medical Association, we're looking at about 14.5% of Canadians over 12 years old don't have a family doctor. And future modeling trajectories are looking about this number is going to be closer to 20% in the next few years, okay? By integrating a PA, we have the potential to see more patients, increase service provision, and not only that, we can increase this patient roster. We were talking about that team-based care or team-based model of care, and this is really advantageous for a lot of Ontario family health teams or the other provinces that have integrated family health teams where they have specific bonuses or premiums for community-centered primary care teams. The last thing we really want to talk about before we get into our limitations is where do we go from here? What model do we select? I know there's been a lot of mention. We went through several scenarios. We went through hundreds of numbers. Where do we land on? So it would be our recommendation, and again, this is not going to apply to every setting. This is based off the statistics and the data and the markers that we were looking at for this project. It'd be our recommendation that we go with the employer-based PA funding model, okay? And there's a couple reasons behind that. First and foremost, we're going to have a massive increased savings to the healthcare system, about $585 million per year. Next, we still get that big service provision, all right? This is assumed that every physician is going to take that time for non-work related activities. If you see below, for primary care, we had 1.8% for non-work related activities, for emergency medicine, 52%, and for orthopedic surgery, 19.8%. This is likely gonna change. Like we said, some physicians are likely gonna put this time back into practice, which is honestly just going to basically further impact to a positive degree the model that we were really talking about here, okay? The indirect benefits are also important to really chat about here, okay? We've talked about this from the beginning. If we're looking at a team-based model of care, one of the most important things is the relationship between the PA and the physician, and the supervising physician, okay? If we're talking about being able to have more autonomy, we're talking about being able to see more patients, this really all intertwines the point we were trying to hit home of increased practice efficiency, okay? One thing that we do acknowledge, first and foremost, is the supervisory role is going to change by practice setting. We know this, okay? Primary care, a lot more autonomy in some circumstances. Emergency medicine, shift work, might not see that supervisory relationship build as strongly. It might in smaller community practices, but might not in larger city centers. In orthopedic surgery, if you're working with the same surgeon over and over again, this is again going to increase trust, going to increase workplace efficiency. And we think that the indirect benefits, because to a physician, if they see these figures and have the opportunity to have more efficient practice and get out on time with the PA, pretty sure they're going to take that option, all right? Let's talk about some model limitations before we wrap this up today, guys. So first and foremost, I think that this has been very clear from the get-go of this project. There is a lack of PA data across Canada, okay? And especially in specific settings, which we're going to go into a little bit more detail later on, okay? What we really need to see here is increased quantitative data for PAs specific to practice setting and workplace characteristics. Furthermore, we need clearer role identification in these healthcare system databases like our EMRs, okay? For a lot of circumstances, we look to find PA data or PA proportion of time in practice, and there was no differential between the physician and the PA. So it's really hard to find these markers and actually map these onto the potential impact of the PA. So for our purposes, we did include expert reviews to inform a lot of our models. We didn't do this from a single interview. We tried to do as many interviews as possible, find publicly available data to support our evidence, and basically created our models about that or off that. But it is a note of a limitation and something we would like to obviously address moving forward. Next is going to be our primary care setting. So to further that impact from the last slide, we really found that out of all practice setting, primary care was awful for finding anything about PAs, okay? Now, we do understand that primary care practice across Canada changes quite broadly. You know, a community up in Northwest Territories versus downtown Toronto family health team, the dynamic is very different and the PA role is very different. We talked to some physicians up in northern and rural, and I think they were in Yukon or BC, where they were discussing that, you know, physicians didn't want to go work, but they could hire PAs. Okay, so the PAs were actually the backbone of this practice for the most part. So I think that this is really, I think this enforces the fact that we need to capture this data. We need to know about the impact potential, and I think it needs to be publicly advertised. Okay, so for our purposes, the best data really we could find was on Ontario family health teams. Okay, so that's both a blessing and a curse in some regards. First and foremost, it incorporated that team-based approach. So it actually gave us a reflection of what that incorporation of PAs into this team-based practice that we've been preaching kind of looked like. Okay. However, although there is some provinces that have this trajectory towards this primary care model, it's not transferable all across Canada. Okay, and we understand that. All right. So really, in the future, if we're looking to kind of create a stronger model, we're going to need to look at site-specific data, basically. Next, we want to talk about data set selection. So you note that we talked about a little bit earlier that we used 2020, 2021 fiscal year CIHI data, the healthcare utilization data from CIHI. This was the most complete, recent, and publicly available source that we could use, okay? Now, we have to understand that there's limitations to this data set as it's a few years old. Number one, there's likely decreased service provision due to the recent pandemic. So basically what we did was backmapped all of the years from 2018 leading up to our data set to see if there was any change in service provision, okay? And really what we found was that our data set compared to pre-pandemic rates was down between 5.8 and 11%, okay? So all this actually does is tell us that our model would have had more impact, okay? We just have decreased service provision in the data set that we used. And last but not least, just building off that is going to be the pan-Canadian data set, okay? This ended up being incredibly difficult to do. Each province fee schedule, each province how they consider codes and pay are very different, all right? We were lucky enough to have a pan-Canadian data set that we could really build off, but there's variation, okay? A good example of this is a lot of variation in provincial service codes. So what happened was some services were combined together, and we kind of had to need those out and figure out what service, so to ensure that all the services that we included were within a PA scope of practice. Next is going to be the combined practice areas. Unfortunately, and we had multiple meetings with CIHI about this, they bunched primary care and emergency medicine, okay? I think the biggest thing, the two areas were very easy to decipher and differentiate which services were in each practice setting. The bigger difficulty is the cost over and underestimation, okay? Likely what happened is going to be, if we were to map this onto family medicine specific data, we'd be looking at a lower cost per service, but a higher cost per service in the emergency medicine, okay? Essentially, these have approximately evened out for our purposes, but I think that, again, it's a limitation of the study and something that we should know. Last but not least, there is zero territorial data from Yukon, Northwest Territories, or Nunavut, okay? This rural data is incredibly important and something that we need to kind of address, as there is a lot of likely potential for PA integration into these territories. Last but not least, Quebec, okay? Quebec has its own healthcare monitoring system, so they do not contribute data to CIHI, all right? And that's, again, a limitation due to the large city centers contained in Quebec. Future direction, where do we go from here? Okay, I have 10 minutes left. This is going to be the wrap up, guys. I appreciate you sticking with me. I think the biggest thing we've realized is that we need to expand this model, okay? We've created a pan-Canadian model for these three practice areas, but really we need to look at nitty-gritty practice-specific data to better model this impact and what that would look like for individual provinces, and like I said, individual practice settings within the province. Good example of this, we use fee-for-service model, although it is used broadly across Canada. Some settings, good examples, emergency rooms in a lot of circumstances, use the specific practice or use the alternative payment agreements, which are very broad across Canada. So obviously we couldn't incorporate those, but again, something to consider. Next, future model adjustment for specific care setting and provincial funding figures, okay? Like I just said, we need to know actual data of how PAs are integrating or influencing and impacting these practice to get accurate, reportable numbers on time and cost savings. Last but not least, I think you guys all need to give yourselves a pat on the back. PAs have tremendous potential and opportunity for further integration across Canada, and tremendous impact potential on from both a patient perspective and a healthcare perspective as part of a larger team. So fantastic news. This report was actually just released this morning, so it's going to be on the Conference Board of Canada website. If you guys have any questions, or if you have some time after this conference done, I know there's a tight schedule, but I encourage all of you guys to look at it. There's a lot of work that went into this, and we're very proud of it. So thank you guys. Yeah. And on 9 minutes.
So there is time for questions. What I would ask, because this session is being recorded, if you have a question, kindly step up to one of the mics, and that way it can be recorded for all of time.
Hi, really good work. Thank you for your presentation. I think we're all really excited to hear the work that you've been putting in, and I had a couple of questions, if you don't mind. So my first question was, since your suggestion is to work on an employer-funded model, that's the recommendation, could you please address how you would suggest approaching a couple topics, number one being benefits such as retirement, health insurance, etc., because this becomes a little bit more complicated in that situation. Additionally, it can occasionally put the PA in a really uncomfortable scenario, particularly if there's only one or two docs that are funding that PA when you're discussing a pay raise.
Yeah, no, that's fantastic. I'll address the first question. So one of the things that we looked at in this were obviously very black or white. We looked at a public versus employer remunerated. And I think really the conversation and the next conversation that needed to be had is the potential for hybridized, okay? It's very difficult to map on to these models, okay? But I think it has potential. It'd be a lot easier if it was site specific, okay? And I think that might address some of the conversations about benefits, et cetera, especially in a practice setting where it's a larger practice setting, it's an established organization, et cetera. I don't know the intricacies amongst an individual physician or a group of physicians. Obviously, I would have to look into that to fully answer that question. If we want to go, sorry, what was your second question?
On the employer-funded model, especially if there's only one or two docs, it can be uncomfortable to sit down and say, you have this really great working relationship, and now I want you to pay me more, and it can be a challenge to sit down for that.
Oh, Patrick.
Can't help myself. This one's important to me. In the U.S., where this happens, at APA, they teach the PAs to bring their utilization to the physician to make the case for compensation, because there's a direct correlation with billing, right? So it's actually, to me, the evidence suggests it's quite the opposite experience in the U.S.
Well, as someone who has definitely worked in the U.S., I would say it's not very comparable, because you're often arguing for your pay increase with to different people, not necessarily the direct doc. There's a few situations where the direct doc is the one funding you, but oftentimes it's not, so you're arguing for that pay raise in a different way. And also, you can also be put in a room with all the other clinicians, and they'll compare your costs publicly. So you're ordering tests and costing this facility this much money, and this PA is only costing us this much. It's a bit uncomfortable. So I think we can come up with a better model for that. I just noticed that as something that we should address within that. But Patrick, you bring up a good point, because and we've talked about this before, about can we develop something where it makes it easy for us to track what we do to make those conversations happen?
I think, yeah, to further your point, and I know Patrick's point as well, amongst my research looking at the fee-for-service model in the US, that was something that came up quite broadly, was the actual evaluation piece and how they calculated the fee-for-service. They used this broad fee-for-service of 85%, but the actual physician assistant actually might not see that unless they see a certain amount of patients, et cetera, moving forward. So this was something that I found really interesting, but to your point, I think really what we need to do is better qualitative analysis on actually how that supervisory relationship works. And I think that if anything moving forward, we just need better access to these opportunities to discuss for both parties what works for them and how that structure would really work.
Okay, fantastic. I also had two kind of comments, I guess. I'm hoping that when you put this together and you list up what PAs, what work our docs doing that PAs can do, and then you came up with the percentages, I'm hoping we can actually use that to demonstrate that PAs, and change the language, PAs don't see simple patients.
Yep.
And MDs don't see the only, are not the only ones seeing complex patients, that we actually do complex work, see comorbid patients. So that's my comment. And then my other comment is that you're absolutely right, we need more data. There are some data sets that are not published from Manitoba that we would love to help in any way, particularly from access centers where PAs are funded. And additionally, I was thinking that remote work should be its own separate category.
Yeah, and those are all fantastic comments. I think first and foremost, the discussion over a complex patient cohort, and I did try to clarify that, and I'm sorry if I didn't do a good job with that. The data suggested about the generalized patient population, and like I said, through our expert reviews, through our interviews, our qualitative interviews, we found the exact opposite. So like I said, we saw PAs seeing the more complex patient cohort, and this is really what threw some of our figures off and really what made it difficult specifically for primary care, because the PAs within the scope of practice or the percentage of time practice, they might be seeing half the patients that physicians are seeing, but that's because they're seeing a more complex patient cohort, okay? So this is something that we did want to emphasize, that there is the option for both, and I think that other point about increasing experience and increasing that supervisor relationship really can build that opportunity. With regard to the rural and remote health, 100% agree. And there is limitations and there's assumptions that we made in this model. Like I said, moving forward, we need to look at site-specific data. It's going to be impossible to make these assumptions across the board. It's not going to be applying to all settings, but I think this gives us the first and foundational funding opportunity that we can take a look at and say, look at the impact potential, okay? It's not perfect, but look at the impact potential. And then it's going to kind of create the conversation for step 2.
Thank you. Can you remind me, was there any net profit for any of the public employed, right? It was all net loss.
No, there was potential profit for some public.
Like column B.
Yeah, there was in some instances, yes.
Okay.
Yep.
I guess I'm just sort of fearful, do governments actually care about disease prevention, the qualitative BS, when they see these red, so what would the Conference Board of Canada, in terms of marketing PAs, like what would be the best sort of spin-off? We see in ortho, we have a profit. Like, so is it actually going towards the docs, or what's your strategy for that?
Yeah, so the profit for the most part, it was marginal. When we met with we actually met with several economic analysis or analysts in the field. I'm not going to mention the organizations that they worked for, just to discuss how we were going to frame this around policy, okay? And really what our approach was here was effectively to, number one, create a basic cost neutral approach for incorporating the PA, okay? So that was for the employer remunerated model, as well as create the cost savings for the healthcare system, okay? That was our approach. We're not looking to, definitely, the model wasn't looking to support increasing the income potential of the healthcare system. It was more looking at cost savings that may be able to be placed in other avenues or other areas of the healthcare system. I'm not entirely sure. I'm not involved in policy for the most part, so I'm not sure what they would do with the money that they have. But yeah, our goal for this, and this is why we say there's multiple ways to run this model. It's incredibly complex. There's a lot going on in it, but there's ways to manipulate it. And our goal here was, like I said, to basically create a cost neutral approach of integrating that PA, increasing the time. It's basically a cost benefit analysis in assumption. Does that answer your question at all, sort of? In terms of the public funding stream, yeah, and like I said, it went both ways. There was potential for savings and there was potential for cost. Okay, I think that they can see those numbers. I would hope that they don't lose sight, especially the areas really where we saw that cost savings is typically in the lower percentage, okay? If we looked at the 100% back into practice, that's gonna be obviously tremendous cost to the healthcare system. But yeah, I would say, I mean, I hope they look at all the lines, especially the line before it that says, you know, there's 10 million services being provided additionally. But yeah, I can't speak for policymakers and how they're gonna be interpreting. The data's all there. I would hope that they're a little bit more careful about analyzing it, yeah. Awesome.
Thank you very much for the wonderful questions and the great answers. Chris, that presentation was exactly what we wanted to hear, and we really look forward to the impact that this work is going to have on future advocacy work. Thank you very much.
Appreciate it, guys. Thanks, Bill.
So I think the next thing is a little bit of a raid on the coffee line, all right? And while we figure out, yeah. So thank you very much for the excellent questions, and we look forward to the next sessions.